The International 1020 system serves as the global standard for scalp electroencephalography. It requires technologists to physically measure the patient's head using specific anatomical landmarks to determine exact electrode placements. In clinical practice, high patient volume, understaffing, and ingrained habits push labs away from this standard. Technologists frequently adopt visual estimation shortcuts to accelerate the setup process. The American Clinical Neurophysiology Society is explicit about this deviation. Guideline 1 states that if the head is not physically measured, the setup must be documented explicitly as an estimated 1020 placement. Despite this requirement, technologists rarely document when they estimate locations, creating a silent discrepancy in the patient's medical record. The ACNS explicitly labels these unmeasured approaches undesirable and misleading, yet they remain common in daily workflows. Relying on visual shortcuts normalizes an undocumented deviation from clinical standards. It compromises the structural foundation of the test before a single electrical waveform is recorded. Many technologists justify estimation by arguing that a standard 30-minute routine EEG is not being used for pre-surgical epilepsy evaluation, assuming that millimeter-level precision is totally unnecessary. This confuses two distinct types of accuracy. Mathematical spatial accuracy provides the 3D coordinates required for advanced calculations, like inverse problem modeling and source imaging. This is the only application where millimeter-level digitization is truly required. Proportional measurement accuracy, the 1020 standard, serves a different purpose. It ensures electrodes are placed at specific percentage intervals relative to the individual patient's skull. Routine EEG is a diagnostic tool. Identifying focal abnormalities, determining lateralized slowing, and establishing anterior versus posterior dominance all require an accurate spatial distribution across the scalp. While the mathematical models in column A require 3D coordinates, the diagnostic requirements in column B rely entirely on the proportional measurement of the 1020 system. Conflating the fact that exact coordinates are not critical for inverse math with the belief that placement accuracy does not matter at all is a logical error. It jeopardizes the diagnostic baseline relied upon by the entire neurology care team. The true 1020 system relies on a specific geometric physics. It requires the exact proportional intersections of arcs and circumferences across the individual patient's head. When mapped correctly, the symmetrical grid rests on the scalp, anchored perfectly by physical landmarks, the nasion at the bridge of the nose, and the inion at the base of the skull. Attempting to visually estimate a 10% or 20% distance between these points bypasses the geometry, creating inconsistent inter-electrode spacing. When an estimated grid is applied, the midline electrodes immediately begin drifting off-center. What a technologist perceives as a visually close estimation can physically shift an electrode several centimeters from its intended target. If the F3 electrode drifts too far posterior, it begins recording electrical activity more representative of the central C3 region. If the T7 electrode shifts superiorly, it moves outside its optimal recording field, meaning temporal discharges can be missed entirely. A visually clean, artifact-free tracing can successfully hide a structurally collapsed spatial framework. This presents the interpreting physician with compromised data disguised as a pristine recording. Physicians locate the origin of a seizure or spike using apparent voltage maxima. This is the principle that the electrode closest to the source of the brain activity will record the highest electrical amplitude. This interpretation inherently assumes the technologist has placed the electrodes in their standardized, mathematically correct locations. This tracing shows a single right temporal spike and wave with a regional temporal field during drowsiness. Identifying this specific regional temporal field requires precise geometry to accurately capture the maximum negativity and phase reversals. A phase reversal occurs when the deflective peaks of two channels point toward each other, marking the focal point of the discharge. If the technologist visually estimated the placement of the T8 and P8 electrodes, positioning them too far interiorly, the recorded field geometry changes completely. Mapping this onto a topographical layout shows how altering the electrode coordinates physically shifts the apparent voltage hotspot. As a result, a discharge actually originating at the T3 location might artificially arise from the frontal F7 position simply because of a physical placement error. The interpreting physician cannot mathematically correct for this geometric drift. If the technologist shifts the voltage maxima through poor placement, they dictate a false localization to the physician. Much of routine EEG interpretation relies on comparing the left hemisphere's electrical activity against the right hemisphere. This diagram displays a symmetrical alpha rhythm, the normal background activity seen in relaxed, awake adults. If we introduce a 2-centimeter asymmetrical placement error on the right side, the recorded amplitude visibly drops. This technical asymmetry creates a false lateralization. It tricks the physician into diagnosing focal slowing or a unilateral lesion where none actually exists. Lack of measurement also creates major vulnerabilities in serial EEG comparisons used to monitor intensive care patients or track epilepsy over time. Consider a patient receiving an EEG on day 1 from Technologist A and a follow-up on day 3 from Technologist B. Both use visual estimation rather than a tape measure. The differing visual biases of 2 different technologists guarantee 2 different spatial frameworks for the same patient. Apparent changes in the waveform over time may merely reflect these physical placement differences, rather than actual physiologic changes or responses to treatment. Without standardized physical measurement, the comparative data is corrupted. The physician is effectively blinded to the patient's true clinical progression. Spatial distribution remains a non-negotiable component of epilepsy diagnosis and interpretation. Advanced interpretive factors, including phase reversals, field spread, and maximum negativity, rely entirely on correct electrode geometry. Sloppy placement carries external consequences. Failing to measure affects lab accreditation, invalidates credentialing exam standards, and strips away medico-legal defensibility under ACNS guidelines. Proper proportional 10-20 measurement using a physical tape measure provides the only defense against these cascading clinical failures. The physical act of meticulously measuring ensures that every single electrode is permanently anchored to a precise, mathematically correct location on the patient's scalp. The EEG technologist physically builds the spatial framework that dictates every subsequent clinical decision. A physician's report depends entirely on the accuracy of the coordinates provided by the technologist. Ultimately, quality patient care begins directly at the scalp. Precise physical measurement establishes the only reliable path to achieving absolute diagnostic truth.